So one of my favorite topics in the treatment of IPF is comorbidities. And the reason is, while it's great to have new pharmacotherapies that help treat these patients, I continue to tout that I can do more for the patient by ensuring that we take care of their comorbidities than anything that's out there. And that's not just true of IPF, that's true in a lot of different disease states. And so it's important to recognize that this is a systemic disorder, that while the primary impact is in the lungs, that we see arterial hypertension, diastolic dysfunction, pulmonary hypertension, that coronary disease is multivessel coronary disease, 4 times more common in an IPF patient than a non-IPF patient, 6 times more likely to get lung cancer, higher rates of depression, reflux disease is in 60 to 80% of these patients. These things matter. How do they matter, right? We know that if there are acute and chronic infections, we can treat those with broad-spectrum antibiotics. We can reduce immunosuppressive regimens for those that might have connective tissue disorders that are being treated. We can focus on specific therapies. Reflux. There's a growing body of evidence that the use of proton pump inhibitors in patients with documented reflux may have improved outcomes in retrospective data sets, and most recently demonstration that use of nissen fundoplication as a treatment option. Pulmonary hypertension tends to run pretty rampant in these patients, particularly at the end of the disease, particularly in IPF, towards the very severe elements of the presentation. Whereas in things like sarcoidosis, we have a subgroup that will often have squeezing of the pulmonary vasculature as a result of the sarcoid that may benefit from PAH medications. And certainly scleroderma has been treated for years with endothelial receptor antagonists, as an example. When we think about the cardiac disease, obviously we know there's a much higher prevalence, but sarcoidosis, as an example, can target the heart itself and may require intervention by an electrophysiologist. We know there are higher rates of DVTs and PEs in these patients, really demanding that they get treated with anticoagulation. How many times have I actually sent a patient to the thoracic surgeon to remove a lung cancer? They will die of their lung cancer before they die of their IPF, and so that's important to treat. We know there's concurrent sleep apnea, and a CPAP machine is a simple treatment. And there's no reason not to treat depression in these patients. Even if there is a justifiable cause for the depression, the role of antidepressants is clear. When we think about the overview of the pulmonary vascular disease in these patients, it's not difficult to appreciate why this would happen. As the dead space increases and the VQ mismatch worsens, right, that's going to put a strain on the heart. And that's going to lead to more cor pulmonale or right heart failure, forcing loss of cardiac output and loss of oxygen delivery, leading eventually to shortness of breath, muscle fatigue, loss of exercise capacity. And so we want to make sure that these things get treated as best we can, and we have lots of treatments for this particular aspect that's been observed in these patients. What further testing should we engage in? Well, when we're diagnosing these patients, we're really trying to exclude other possibilities. And so I always tease that while the guidelines recommended an ANA, ESR, and a rheumatoid factor when they first came out, they're growing in their point of view, recognizing that a significant number of patients will have positive serologies for various connective tissue disorders, even without a positive ANA. So things like a rheumatoid factor and an anti-CCP in patients who may be concerning with morning stiffness or a rash for an underlying diagnosis of possible rheumatoid arthritis. Dry eyes, dry mouth may indicate Sjogren's and warrant an SSA and an SSB, whereas esophageal symptoms and Raynaud's may warrant an SEL70. And likewise for proximal muscle weakness or mechanic's hands, really demanding a CK or an anti-Joe to pick up a polymyositis. It's important to remember the psychosocial aspect as well, and realize that this is pretty devastating for most patients that hear about this disease. And so we try to provide all of this care in collaboration in a multidisciplinary team, making sure that from a comorbidity standpoint, we've had a discussion with cardiology if appropriate, or with the gastroenterologist if a nissen fundoplication is necessary. That type of collaboration reassures the patient that they're getting the best possible care, including the psychiatrist or psychologist if there's depression. And of course, the primary care doc cannot be forgotten, right? They're the ones that are our gatekeepers. They're the ones that are going to see these elements first. And so cueing them into what the possibilities are is very important for early intervention. And that collaborative holistic approach really helps us manage the comorbidities, screen and manage for complications of the therapies and their comorbidities, and help provide palliative care when appropriate.